Psychiatric Interview, History and Mental Status Examination. I am Dr. VAIBHAV CHATURVEDI, Assistant Professor, Department of Psychiatry at Index Medical College, Indore. The psychiatric interview is the most important element in the evaluation and care of person with mental illness. A major purpose of the initial psychiatric interview is to obtain information that will establish a criteria-based diagnosis. This process helpful in the prediction of the source of the illness and the prognosis leads to treatment decisions. A well-conducted psychiatric interview results in a multidimensional understanding of psychosocial elements of the disorder and provides the information necessary for the psychiatrist in collaboration with the patient to develop a person-centered treatment plan. At the beginning of the interview, the psychiatrist should introduce himself or herself and depending on the circumstances may need to identify why he or she is speaking with the patient. Unless implicit, consent to proceed with the interview should be obtained and the nature of the interaction and appropriate amount of time for the interview should be stated. A crucial issue is whether the patient is directly or indirectly seeking the evaluation on a voluntary basis or has been brought in voluntarily for the assessment. Confidentiality is an essential component of the patient-doctor relationship. The interviewer should make every attempt to ensure that the consent of the interview cannot be overheard by others. A special issue concerning confidentiality is when the patient indicates that he or she intends to harm another person. When the psychiatrist's evaluation suggests that this might indeed happen, the psychiatrist may have a legal obligation to warn the potential victim. If a family member wishes to talk to the psychiatrist, it is generally preferable to meet with the family members and patient together at the conclusion of the session and after the patient consent has been obtained. The psychiatrist should not bring up material the patient has shared but listen to the input from family member and discuss items that the patient introduces during the joint session. As always, the patient must give consent except if the psychiatrist determines that the patient is a danger to himself or others or herself. Except in an emergency, consent should be obtained from the patient before the psychiatrist speaks to the relative. The patient should be told when a family member has contacted the psychiatrist, even if the patient has given consent for this to occur. In educational and occasionally forensic setting, there may be occasions when the session is recorded. The patient must be fully informed about the recording and how the recording will be used. Because of the stigma of mental illness and misconceptions about psychiatry, the patient may be especially concerned or even frightened about seeking a psychiatrist. The skilled psychiatrist is aware of these potential issues and interact in a manner to decrease or at least not increase the distress. The success of initial interview will often depend on the physician's ability to allay excessive anxiety. Then this is rapport. How to establish rapport? In the clinical setting, rapport can be defined as the harmonious responsiveness of the physician to the patient and the patient to the physician. It is important that the patient increasingly feels that evaluation is a joint effort and that the psychiatrist is truly interested in their story. Empathetic interventions further increases the rapport. Means that must have been very difficult for you, or I'm beginning to understand how awful that felt. These are some lines which increases the rapport. Frequently, a non-verbal response means raising eyebrows or leaning towards the patient, or very brief response, wow, will give the similar effect. Head nodding, putting down one's pen, uh, leaning towards the patient, or a brief comment, I see, can accomplish this objective and simultaneously indicate that this is important material. In fact, the large majority of the empathetic response in an interview is a non-verbal. So next is patient-physician relationship. Right from very first encounter, the patient willingness to share is increased or decreased depending on the verbal and often the non-verbal intervention of the physician and other staff. Being able to laugh in response to humorous comment, admit a mistake, or apologize for an error that inconvenience the patient, being late for or missing an appointment, these not to be done from a physician's side. For patient being seen for supportive psychotherapy or medication management, answering the question, especially if it is not very personal, such as do you watch football, is quite appropriate. No problem arises asking this question. A major reason for not answering personal question directly is that the interview may become psychiatrist centered rather than the patient centered. Occasionally, again, depending on the nature of the treatment, it can be helpful for the psychiatrist to share some personal information, even if it is not asked directly by the patient. So, psychiatrist may or may not share his personal information. In the interview, transference and counter transference are very significant expression of unconscious process. Transference is the process of the patient unconsciously and inappropriately displacing onto individual in his or her current life those pattern of behavior and emotional reaction that originated with significant figures from earlier in life, often childhood. In the clinical situation, the displacement is onto the psychiatrist, who is often an authority figure or parent surrogate. It is important that the psychiatrist recognizes that the transference may be driving the behavior of patient and the interaction with the psychiatrist may be based on distortion that have their origin much earlier in their life. The patient may be angry, hostile, demanding, or not because of the reality of the relationship with the psychiatrist, but because of the former relationship and the pattern of behavior. Similarly, countertransference is the process where the physician unconsciously displaces onto the patient pattern of behaviors or emotional reaction as if he or she were a significant figure from earlier in the physician's life. Psychiatrists should be alert to sign of countertransference issues, missed appointment by the psychiatrist, boredom or sleepiness in a session. Now we will discuss person-centered and disorder-based interview. A psychiatric interview should be a person, means patient-centered, not psychiatrist-centered. That is, the focus should be on understanding the patient and enabling the patient to tell his or her story. Traditionally, medicine has focused on illnesses and deficit rather than strength and assets. During the assessment, it is often helpful to ask the patient, tell me about some of the things you do best, or more open-ended questions such as, tell me about yourself, may elicit information that focuses on either strength or deficit depending on number of factors including the patient's mood and self-image. Now there is another we will discuss another thing, which is safety and comfort. Both the patient and the interviewer must feel safe during the interview. This includes physical safety. In emergency room setting, it is generally advisable for the interviewer to have a clear exit path. Patients, especially if psychotic or confused, may feel threatened and need to be reassured that they are safe. And the staff will do everything possible to ensure their safety. The interview may need to be shortened or quickly terminated if the patient become more agitated and threatening. A direct question may be helpful in not only making the patient feel more comfortable, but also enhancing the patient-doctor relationship. This might include, is that chair comfortable for you? Or some simple questions. As the interview progresses, if the patient desires tissues or water, it should be provided. Time and number of session. For initial interview, 45 to 90 minutes is generally allotted. For inpatient on a medical unit or at time for patients who are confused is considerable distress or psychotic, the length of time that is can be tolerated in one setting may be of 20 to 30 minutes or less. The clinician must accept the reality that the history obtained is never complete or fully accurate. Now, we will discuss about the process of interview. So, things to be done before the interview. For outpatients, the first contact with the psychiatrist's office is often telephone call. It is important that whomever is receiving the call understand how to respond. If the patient is acutely distressed, confused, or expresses suicidal or homicidal intent. So, so the timing of the appointment should reflect the apparent urgency of the problem. Asking the patient to bring information about past psychiatric and medical treatment as well as list of medication or preferably the medication themselves can be very helpful. Whether or not records are reviewed, it is important that the reason for the referral be understood as clearly as possible. This is especially important for forensic evaluation, where the reason for the referral and the questions posed will help to shape the evaluation. During the waiting room, when the patient arrives for the initial appointment, he or she is often given forms to complete. These generally include demographic information. Many practice also ask for a list of medication and identification of major medical problem and allergies. Sometimes the patient is asked what his or her major reason is for coming to the office. Increasingly, some psychiatrists ask the patient to fill out a questionnaire or a rating scale that identifies major symptoms like patient has questionnaire 9 for depressive disorder. During the interview room, the interview room itself should be relatively soundproof. The decor should be pleasant and not distracting. Many psychiatrists suggest that the interviewer chair and the patient chair be of relatively equal height so that the interviewer does not tower over the patient or vice versa. In same level, means for good eye contact. It is generally agreed that the patient and the psychiatrist should be seated approximately 4 to 6 feet apart. The psychiatrist should not be seated behind a desk. The psychiatrist should dress professionally and be well groomed. Distraction should be kept to a minimum unless there is an urgent matter. There should be no telephone or other interruption during the interview from psychiatrist side. The patient should feel that the time has been set aside for him or her and that for this designated time he or she is the exclusive focus of the psychiatrist's attention. Initiation of interview. The patient is greeted in the waiting room by the psychiatrist who, with a friendly face, introduces himself or herself, extend a hand, and if the patient reciprocates, gives a firm handshake. If the patient does not extend his or her hand, it is probably best not to comment at the point, but warmly indicate the way to the interview room. The refusal to shake hand is probably an important issue, and the psychiatrist can keep this in mind for potential inquiry if it is not brought up subsequently by the patient. Upon entering the interview room, the psychiatrist that indicates where the patient can sit. A brief pause can be helpful as there may be something the patient wants to say immediately. Psychiatrists can convey interest support by exhibiting a warm, friendly face and other non-verbal communication such as uh, leaning forward in the chair. It is generally useful for the psychiatrist to indicate how much time is available for the interview. The patient may have some question about what will happen during this time, confidentiality and other issue, and these questions should be answered directly by the psychiatrist. The psychiatrist can then continue with an open-ended inquiry. Why don't we start by you telling me what has led to bring your being here, or simply what has led to your being here? Elements of the initial psychiatric interview. First one is identifying data. Second one is sources and reliability. Third one is chief complaint. Fourth one is present illness. Fifth one is past psychiatric history. Sixth one is substance use abuse. Seventh one is past medical history. Eighth one is family history. Ninth one is developmental and social history. 10th one is review of system. 11th one is a mental status examination. 12th one is physical examination. 13th formulation, and 14th DSM-5 ICD-11 diagnosis. And fifth one is treatment plan. First one is identifying data. This session is brief, 1 or 2 sentences, and typically includes the patient's name, age, sex, marital status, or significant other relationship. Race or ethnicity and occupation, often the referral source, is also included. Sources and reliability. It is important to clarify where the information has come from, especially if others have provided information or records reviewed and the interviewer assessment of how reliable the data are. Reliability refers to the likelihood that similar result will be obtained by different observers, means contact, closeness, continuity, consistency, or how uh, between what is the relation between various sources of information. Collaborativeness, chief complaint. This should be the patient presenting complaint, ideally in his or her own words. Example include I am depressed or I have lot of anxiety. Complaint should be chronological order with the earliest complaint first and recent most being last in list. History of present illness. The present illness in a chronological description of evaluation of symptoms of the current episode. In addition, the account should also include any other changes that have occurred during this same time period in the patient interest, interpersonal relationships, behaviors, personal habits, or and physical health. Details that should be gathered include the length of the time that the current symptoms have been present and whether there have been fluctuation in the nature or severity of those symptoms over time. The presence or absence of stressors should be established, and these may include situation at home, work, school, legal issues, medical comorbidities, and interpersonal difficulties. Also important are factors that elevate or exacerbate symptoms such as medication support, coping skills, if any treatment has been received for current episode, it should be defined in terms of who saw the patient and how often, what was done. Past psychiatric history. In the past psychiatric history, the clinician should obtain information about all psychiatric illnesses and their course over the patient's lifetime, including symptoms and treatment. Description of past symptoms should include when they occurred, how long they lasted, and the frequency and severity of episodes. Past treatment episodes should be reviewed in detail. A special consideration should be given to establishing a lethality history that is important in the assessment of current risk. Past suicidal ideation plan and attempt should be reviewed, including the nature of attempt, perceived lethality of the attempt, suicide note, giving away things, or other that preparation. Substance use, abuse, addictions. History of use should include which substance have been used, including alcohol, drug, medication, and route of use. The frequency and amount of use should be determined, keeping in mind the tendency for patient to minimize or deny use that may be perceived as social unacceptable. Tolerance, the need for increasing amount of use and any withdrawal symptom. Impact of use on social interaction, work, school, legal consequences, and driving while intoxicated should be covered. Any period of sobriety should be noted, including length of time and settings such as in jail. Past medical history. The past medical history include an account of major medical illnesses and condition as well as treatment, both past and present. Any past surgery should be reviewed. Any known history of prenatal or birthing problem or issues with the development milestone should be noted. In women, a reproductive and menstrual history is important as well as careful assessment of potential for current or future pregnancy. Allergies to medications must be covered. Family history. Many psychiatric illnesses are familial, and a significant number of those have a genetic predisposition. Medical illnesses present in a family histories may also be important in the both the diagnosis and the treatment of the patient. Family traditions, belief, and expectation may also play a significant role in the development, expression, or course of the illness. Also, the family history is important in identifying potential support as well as stresses for the patient, and depending on the degree of disability of the patient, the availability and the adequacy of the potential caregivers. Now, there is a developmental and social history. Frequently, current psychosocial stressor will be revealed in the course of obtaining a social history. Any available information concerning prenatal or birth history and developmental milestones should be noted. For the large majority of adult patients, such information is not readily available. Childhood Childhood history will include childhood home environment, including members of the family, and the social environmental, including the number and quality of friendships. A detailed social history includes how far the patient went in school and how old or she was at that level. Work history will include types of job, performance at job, reason for changing job, and current work status. The nature of the patient relationship with supervisor and co-worker should be reviewed. Marriage and relationship history, including sexual preferences and current family structure, should be noted. This should include the patient capacity to develop and maintain stable and mutual satisfying relationship, as well as issue of intimacy and sexual behaviors. Current relationship with parents, grandparents, children, and grandchildren are an important part of social history. Legal history is also relevant, especially any pending charges or lawsuits. The social history also includes hobbies, interests, pets, leisure time activities, and how this has fluctuated over time. It is important to identifying cultural and religious influences on the patient's life and current religious belief and practices. Review of system. The review of system attempt to capture any current physical or psychological sign and symptom not already identified in present illness. Mental status examination. This is very important thing for psychiatrists and for history taking, psychiatric history taking. First one is appearance and behavior. This section consists of a general description of how the patient looks and act during the interview. Does the patient appear to be his or her stated age, younger or older? Is this related to the patient style of dress, physical feature, or style of interaction? Item should be noted include what the patient is wearing, including body jewelry, and whether it is appropriate for the contest. Grooming and hygiene also are included in the overall appearance and can be clues to the patient level of functioning. The description of patient behavior includes a general statement about whether he or she is exhibiting acute distress, and then a more specific statement about the patient approach to the interview. Motor activity. Motor activity may be described as normal, slowed, or agitated, means bradykinesia and hyperkinesia. This can give clues to diagnose depression and mania, as well as confounding neurological or medical issues. The presence or absence of any tics should be noted, as should be tremor, apparent restlessness, lip smashing, and tongue protrusion. These can be clues to an adverse reaction or side effect of medication, such as tardive dyskinesia. Speech. Fluency can refer to whether the patient has full command of the English or regional language, as well as potentially more subtitle fluency issues such as fluttering, word finding difficulties, or paraphasic errors. The evaluation of the amount of speech refers to whether it is normal, increased, or decreased. Decreased amounts of speech may suggest several different things, ranging from anxiety or disinterest to thought blocking or psychosis. Increased amount of speech often, but not always, are suggestive of mania and hypomania. A related element is the speed or rate of speech. It is slowed or rapid. Finally, speech can be evaluated for its tone and volume. Descriptive terms for these elements include irritable, anxious, dysphoric, loud, quiet, angry, or childlike. Mood, defined as the patient's internal and sustained emotional state. Its experience is subjective and hence it is best to use the patient's own words in describing his or her mood. The terms such as sad, angry, guilty, or anxious are common description of mood. Affect, expression of mood or what the patient's mood appear to be to the psychiatrist. Affect is often described with the following element: quality, quantity, range, appropriateness, and congruence. Terms used to describe the quality of patient affect include dysphoric, happy, euthymic, irritable, angry, agitated, tearful, sobbing, and flat. Quantity of affect is a measure of its intensity. Two patients both described as having depressed affect can be very different if one is described as mildly depressed and the other is severely depressed. Range can be restricted, normal, or labile. Flat is a term that has been used for severely restricted range of affect that is described in some patients with schizophrenia. Appropriateness of affect refers to how the affect correlate to the setting. A patient who is laughing at a funeral service is described as having inappropriate affect. Affect can also be congruent or incongruent with the patient's described mood or thought content. A patient may report feeling depressed or describe a depressive theme, but do so with laughter, smiling, and no suggestion of sadness. Thought content. Thought content is essentially what thoughts are occurring to the patient. Obsessional thoughts are unwelcome and repetitive thoughts that introduce into the patient's consciousness. Compulsions are repetitive, ritualized behavior that patients feel compelled to perform to avoid an increase in anxiety. Delusions are false, fixed ideas that are not shared by others. Suicidality and homicidality fall under the category of thought content. Thought process, how the thoughts are formulated, organized, and expressed. Normal thought process is typically described as linear, organized, and goal-directed. Circumstantiality, over-inclusion of trivial or irrelevant details that impede the sense of getting to the point. Clang association means thoughts are associated by the sound of word rather than their meaning. Derailment means a breakdown in the both logical connection between ideas and the overall sense of goal and directedness. The words make sentence, but the sentence do not make sense. What is flight of ideas? A succession of multiple associations so that thought seems to more abruptly from ideas to ideas, often expressed through rapid pressure speech. What is neologism? The intervention of new words of phrases or the use of conventional words in idiosyncratic way. Perseveration, repetition of out of context words, phrases, or ideas. Tangentiality is in the response to the question, the patient gives a reply that is appropriate to the general topic without actual answering the question. Example, doctor, have you had any trouble sleeping lately? Patient, I usually sleep in my bed, but now I am sleeping on the sofa. Thought blocking, a sudden disruption of thought or break in the flow of ideas. Now, we will discuss about perceptual disturbances. Perceptual disturbances include hallucinations, include illusions, depersonalization, and derealizations. Hallucinations are perception in the absence of stimuli to account for them. Auditory hallucinations are the hallucinations most frequently encountered in the psychiatric setting. Other hallucinations can include visual, tactile, olfactory, and gustatory. The interviewer should make a distinction between a true hallucination and the misinterpretation of stimuli. In the case of auditory hallucination, it can be useful to learn if the patient hears words, commands, or conversation and whether the voices is recognizable to the patient. Depersonalization is a feeling that one is not oneself or that some thing has changed. Derealization is a feeling that one's environment has changed in some strange way that is difficult to describe. What is cognition? The elements of cognitive functioning that should be assessed are alertness, orientation, concentration, memory, both short-term and long-term, calculation, fund of knowledge, abstract reasoning. Insight refers to the patient understanding of how he or she is feeling, presenting, and functioning, as well as the patient potential causes of his or her psychiatric presentation. The patient may have no insight, partial insight, or full insight. There are some grading of insight also from 0 to 5, and some authors take 1 to 6. Judgment refers to the patient capacity to make good decisions and act on them. Significantly impaired judgment can be cause for considering a higher level of care or more restrictive settings such as inpatient hospitalization. Physical examination. In the outpatient setting, little or no physical examination may be routinely performed, while in the emergency room or in a patient setting, a more complete physical examination is suggestible. Vital signs, weight, breast circumferences, body mass index, and height may be important measurement to follow, particularly given the potential effect of psychiatric medication. And this is how we formulate the history taking. The formulation should include a brief summary of patient history, presentation, and current status. It should include discussion of biological factors like medical, family, and medication history, as well as psychological factors such as childhood circumstances, upbringing, and past interpersonal interaction, and social factors including stressor क्या feel कर रहा है, and contextual circumstances such as financial, school, work, home, interpersonal relationships. These elements should lead to a different diagnosis of patient's illness as well as provisional diagnosis. So how we plan treatment? The first part of treatment planning involves Determining whether a treatment relationship is to establish between the interviewer and the patient. Cases where this may not be the case include if the interview was done in consultation or for a legal matter or third-party review or in emergency room or other acute setting. If the treatment relationship is not being stated, then the patient should be informed as to what the recommended treatment is. Medication recommendation should include a discussion of possible therapeutic medication, the risk, the benefit of the no medication treatment, and the alternative treatment option. The prescriber must obtain informed consent from the patient for medication initiated. Family involvement in patient care can often be useful and integral part of treatment and require proper patient consent. Thank you.